So, official good morning to everyone. First of all, I would like to thank AOP Bhavnagar team for including me in this wonderful academic fiesta. And just to note that my medical journey actually has started from Bhavnagar Medical College. So, just to little bit of nostalgia. Yeah. So, today's our talk would be like immune system misfires. So earlier we know there was a word of immune deficiency, but this is immune system misfires. You can see in the picture the T cells actually they should attack cold, flu virus, bacteria. This is their normal work. But instead of that, they attack healthy tissues, which is known as autoimmunity. So, earlier known as immune deficiency, primary immunodeficiency, now known as inborn error of immunity. Why? Because there are phenotypes which can present at inborn errors of immunity. As we know, first would be definitely recurrent infections. The next one is early onset autoimmunity, refractory allergy. So there are many other phenotypes that we need to think. And immune system is always great at protection, but not so great at apologies. So what is the concept of immune system misfires? So whenever we see like routine infections, so there are some unusual infections. So there is overlap in the inborn errors of immunity. If routine allergy behaving like a refractory allergy requiring immunosuppression behave like an inborn error of immunity. If you see a SLE patient at very young age, think of inborn errors of immunity. If you see extremely hyperinflammation, think of inborn errors of immunity. And what were the presentation when immune system misfires? Either PO or recurrent fever, which is the commonest presentation in our OPD. And I would say year 2026 PO rule would be before labeling any child with some infection, blame the immune system. So blame the immune system before blaming bugs or tumors. So this talk would be more of a lab clues and clinical clues, not theory and not traditional case-based discussion. So, in our OPD, what are the most common scenarios in POV? PO, we find the scenario one would be only fever and all high. What do you mean by all high? You have seen many such patients that patient presents with PO, no other symptoms, you are not finding any infective focus. Just look at the CBC. If you see neutrophilic leukocytosis, and the most important clue is platelets, higher platelets, thrombocytosis. And when you see ESR more than 120, this all our pediatrician would face this scenario routinely. So these are not rare disorder. Routinely they face it, that PO and all high. So there are just 4 or 5 conditions we need to think. One is Kawasaki. Another most common misdiagnosis in PO, systemic GI, inflammatory bowel disease. We think it's not that common, but in PO with all high, IBD is also common, irrespective of age, 1 year or 2 year. And nowadays we are finding like post-infectious inflammation, post-COVID, post-dengue, post-entry, everything. And lastly, inborn errors of immunity. So when you have a most common scenario, PO with high inflammatory marker, there are just to think of 4 diagnoses. Let's see this simple case. In this, fever is just whispers, but lab is shouting. 9-year girl, fever 18 days, well between spikes. But we need to ask that how the child is between fever. So well between spike, no infectious door spike. And we can see simply by looking at CBC, and just with a one sentence, well between spikes. So it suggests thrombocytosis, ESR more than 120. If you go through this, don't hunt so much for infection. Think of inflammatory diseases. And yes, this is the most missed PO in our OPD, and that is a systemic GI. On the image, which is a classical image, and this rash comes and goes with fever, which is why it is known as evanescent. So, what is the classical clinical presentation? PO, typically, if you ask, there are only 1 to 2 spikes in a day and well between spikes, and you will find rash only during fever. We need to make child naked to see this rash because it comes on the axilla and the thighs. And musculoskeletal symptoms, sometimes parents say neck stiffness, we think of meningitis. Sometimes they think of limp, we think of some neurological causes. But these all symptoms only during fever. Now, and there are some unusual cases. Kawasaki classical, we know. But if you have an infant with all high, with irritability, unexplained shock with all high, cervical lymphadenopathy, all high, sterile pyuria, all high, acute GI disease, all high, thrombocytosis, ESR high. Think of atypical Kawasaki. Now, this was a scenario of PO with all high. Now comes scenario 2, PO with all low, count low or lowish. So this is a typical scenario, HB 9.8, TLC 4,200. It's not like cytopenia, but lowish count. Lymphopenia, platelets, lower side. And see the mismatch, ESR 110 and CRP 4.9. If you have with this CBC, simple CBC report, adolescent girl, PO, you can think of a one simple diagnosis, which we feel it's rare, but it's not. So ESR CRP mismatch and lowish count. We always think of viral infection, malignancy, but the most common cause of PO with cytopenia, we always forget. Let's see what we forget. And this is the hint. It's a wolf bite or something deeper. So this was a 2-year-old girl, PO for 1 month, pallor, mouth ulcer, alopecia, eye loss, floppy infant. And past history, there was dry skin since birth, 8-month necrotic lymphadenopathy, required lots of antibiotics, and no infectious source found. Can anybody has any thought with this CBC, with this presentation, with hint of wolf bite? Can anybody have a diagnosis in the mind, like a thought? Yes. Yes, wonderful. But at 2 years age, would you think of SLE? Usually not. Yes. So usually not, but let's see. That's why I have put something deeper. So these were the report. SGOT 9256, SGPT 1112. Can anybody tell that why, if SGOT is more than SGPT, what is it? Yes, it's a muscle involvement. Wonderful. So SGPT in case of PO is not always comes from fever. If you have SGOT elevation more than SGPT, LDH high, CPK high, think of myositis. So this story of fever, mouth ulcer, alopecia, and now myositis, low albumin, proteinuria, hematuria, TSH very high, and polyserositis. Effusion is there, ascites is there. So there is no uveitis, sir. So this all suggests, and yes, as sir rightly pointed out, we also thought of a SLE, ANA positive, NTSM, which is more specific. dsDNA is more sensitive for lupus. NTSM is the specific antibody for SLE. An anti-thyroid antibody was also positive. DCT, cytopenia, kidney involvement. So yes, it was lupus, but think age less than 5 years. If you see a lupus-like patient, think it is monogenic lupus, which is like a single gene responsible for causing lupus in this child. So this is again an inborn errors of immunity. And mind you, this is like every month, one or two such cases are coming. So it is not that rare. So the most underestimate cytopenias, whenever you see PU and cytopenias, we'll worried about malignancy, malignancy, malignancy. But friends, PO with cytopenia, most common, the childhood lupus presentation, most common is PO and cytopenia. And there would be an ESR CRP mismatch. If you see 2 months of PO and you see such report that CRP persistently negative, ESR more than 100, think of SLE. So, and the first step, if you suspect SLE, simply send ANA by indirect immunofluorescent and C3, C4, not ANA profile as a first step. And don't forget serum albumin and urine PC ratio for proteinuria. Now, this was first we have seen high, then we have seen low. Now see this child, all high, then to all low. Very young infant, 3 months of age, persistent coughing, 4 months presented to us as PUO. On examination, there was encephalopathy, there was hepatosplenomegaly, failure to thrive, left knee arthritis. And this CBC trend, which I am showing, is from like when the child presented like a previous 4 to 6 weeks of CBC, from hemoglobin from 10 to 5.6 when he came, from 34,740 to 3,500 count, and 594 to 30,000 platelet. And friends, one important message I want to, in case of PO, please get two things, ESR and ferritin. In this also, ESR was missing and the trend was like ESR was dropping 80, 55, 21, and ferritin trend was 1,500, 5,500, and 9,800. There are lots of discussions in our meetings and everything about HLH criteria. I just want to remind everyone that whatever criteria is the textbook is just to help clinician to make to think. All are not diagnostic criteria. There are some classification criteria, some diagnostic criteria. So it is not like we need to strictly follow the criteria until label the child that this child is suffering from some hyperinflammation. And this boy actually passed away with criteria because we waited for criteria and child passed. So what can anybody tell that which situation we are dealing with? HLH. Wonderful. So for HLH, there is a different ABC, like airway breathing, CBA circulation in intensive care. But for HLH, ABC is different. A, ACT. B, before. C, criteria. ACT before criteria. So when you start to think of HLH, whether it's primary, secondary, clinical, persistent fever, multi-system involvement. Second thing, don't follow that cytopenia should be there. You have a 1 month PO case, you need to put all into the Excel sheet. So if you are finding hemoglobin is dropping, WBC count is dropping, although not actual cytopenia, platelet is dropping, ESR is dropping, CRP and ferritin rising, this is the stage where we should act. And liver dysfunction and course would be definitely rapid. Child may look sometime okay. So HLH is faster than our suspicious, so referral must be faster than this HLH. Now, again, HLH is just a state of disease. It is beyond the criteria. And hemato-oncologist group has given criteria in 2004 and recently For primary HLH 2024, but in between, rheumatologist group has given 5 different criteria of HLH. So criteria is not important. To suspect early HLH is very important. So simple interpretation, all high, systemic inflammation, Kawasaki, systemic GI, IBD, count lowish, normal CRP, high ESR, think of SLE, and count low, CRP high, ESR low, ferritin high, think of late HLH. And if everything is normal, then yes, our Prime Minister like Achhe din, like every normal count, CRP low, ESR low, everything remains fine. And now last scenario, recurrent fever. Because we have many patients who are coming like, sir, every 2 to 3 months fever is coming. So in this case, we need to find that this fever is infection or inflammation. So that is first thing. So its fever is recurrent or persistent. If we are finding some organism like in sepsis, like some organism like E. coli or some unusual organism, and we need to think, is there any autoimmunity like type 1 diabetes, other arthritis or something like that, or refractory allergy? And most important is CBC. Our CBC will almost give much of the diagnosis, and definitely family history. So the first thing would be phenotype, next thing would be immunotype, and the last would come genotype. From phenotype, if you go directly to the genotype, you'll get confused in immune deficiency. So what are the clinical clues which suggest inborn errors of immunity? Any child less than 6 months, severe infection, think of immune deficiency. And GI inflammation, PO with all high, low iron, low albumin, normal or high ferritin. Think of GI inflammation in absence of GI symptoms. Absent tonsils, very basic thing we can see bedside. Absent thymic shadow, erythroderma, like in newborn, which is a most common presentation of most important medical emergency, severe combined immune deficiency without any infection. Erythroderma, eosinophilia, you need to suspect SCID. And failure to thrive, persistent oral thrush, chronic diarrhea, omphalitis, delayed cord separation. And if you see abscesses, very large skin abscesses or internal organ abscesses like liver, bone, osteomyelitis, lymphadenitis, septic arthritis, think of immune deficiency. And early onset immunity that we have seen, lupus at early age, polyautoimmunity, like in a single child, type 1 DM, arthritis, enteropathy, celiac disease, think of immune deficiency. And unexplained neuroinflammation or early onset stroke, think of immune deficiency. And definitely don't forget family history. And the signature pathogen in the cultures, if intensive, it find like BCOGs, recurrent tuberculosis, it cannot be resistant TB, it can be immune deficiency. MRSA, Burkholderia, Aspergillus, Candida, EBV, CMV. If you find such organism, think of immune deficiency. And simple CBC. In PO case, if you see CBC, there are many cases who presented with persistent neutropenia and recurrent infection. So yes, it can suggest immune deficiency. Think of lymphopenia in very young age. Think of SCID. In anemia, anemia of chronic disease, think of systemic inflammation. If there is autoimmune hemolytic anemia, which is not a diagnosis anymore, it is the most common presentation of immune deficiency. And the most important rheumatologist friend is thrombocytosis. If thrombocytosis, you think of systemic inflammation. So CBC, this simple CBC
Speaker,
would be,
kindly note, you have 2 minutes left.
yeah. So thrombocytosis, which is like a rheumatologist friend. And if you have a persistent or recurrent fever, some typical CBC abnormality, for that we need to see CBC and differentials, then think of immune deficiency unless proven otherwise. So now, up to now, from last 2.5 to 3 years, what we have achieved at Ahmedabad, like in phenotype, around 250 cases, and we are counting. And immunology test, there are many immunology tests which was not available that we have developed. In genotype, I think next speaker would be more elaborate. And management wise, earlier it was like we as a pediatrician diagnose immunodeficiency and it's just diagnosis is a eureka moment. No, diagnosis is the start. The journey is big. So there are more than antibody and more than antibiotics prophylaxis. So there are targeted molecules. And now we have started exclusive bone marrow transplantation for immune deficiency patient as well. And we have developed a network of scientists which can prove our VUS, because whenever we send genetics, we are worried of VUS, but we are getting functional tests to prove that VUS. So at that stage, we have reached now. So if anybody has any queries or questions, they can. So think of immune system misfire. If fever not settling, either PO or recurrent fever, your antibiotics are not working, multi-system, your labs are not matching, all high, all low, high to low, unusual infections and HLH. Yeah. Thank you very much.